This program is brought to you by Emory University.
I'm Jim Curran. I'm Dean of the Rollins School of Public Health, and I'm moderating this session on healthcare and health issues. And we have one challenge and two panelists. What I'm going to do is introduce our two panelists, and then they will speak for about 10 or 15 minutes each, and then we'll have a discussion and question and answer period afterwards. Our two panelists, and the challenge, of course, is going to be time. But the wonderful thing is that our two panelists have both much in common and much to differentiate them. They really have four things, I think, at least in common. They were both born in India. They are both physicians, and they are both Emory faculty members. And they are both interdisciplinary and world scholars and scientists. Dr. Majmudar is an amazing man. He's a professor of pathology and obstetrics and gynecology. And in addition to being a physician, he's a Hindu priest. He's won the Papa George Award for teaching as the highest award for teaching at the Emory School of Medicine. And he's been a very, very strong leader of the Indian community here in Atlanta. He teaches Sanskrit as well as officiates at Hindu weddings. And he, for the last 3 years, has been a Gustafson Scholar, which is an interdisciplinary inter-school scholar here at Emory. It's very unusual, I can tell you, for a physician and practicing scientist in the School of Medicine to find time to do almost anything, let alone officiate at Hindu weddings and be a Gustafson Scholar and be the Teacher of the Year. So I'm looking forward to him. In his spare time, he's a playwright and an actor and has written award-winning poetry. Now, I know well Dr. Venkat Narayan for many, many years, from his time at the National Institute of Health and his time at the Centers for Disease Control before he joined us as a Hubert Professor of Global Health and Epidemiology and Medicine in the Rollins School of Public Health and the Emory School of Medicine. In addition to his MD from St. John's College, he has a Master of Science from the University of Edinburgh and a Master's of Business Administration at Heriot-Watt University. He has hundreds of peer-reviewed publications in the area of diabetes and chronic diseases that are both global and national threats. And he's an active leader in various clinical trials in prevention of diabetes and its complications and management of diabetes throughout the world. In his spare time, he himself is an inveterate learner and teacher. He teaches us, he teaches students, he mentors young junior colleagues from around the world, and he mentors while he's on planes, in addition to the time when those planes land at various continents throughout the world. So trained in 3 continents, he doesn't limit his interests in the world to only those continents, but he is someone who is a true interdisciplinary scholar. We're going to be changing our rotation around at the request of the speakers, so Dr. Narayan will go first.
Thank you, Jim, and good morning, my dear friends. There was a reason why we decided to change the order, because as you heard, Dr. Majmudar is a priest. So if I went first and said all the sinful and blasphemous things, he can then pray for my soul. So that's the belief in which we enter this early morning session. So what I'm going to do in the next 10 minutes is really reflect on my experience over the last 4 years after coming to Emory in terms of setting up collaborative research relationships with India, and then also from that distill out some personal lessons that I have learned in the process, which may be of wider application. Just to give you a little context, I'm in the School of Public Health, and over the last 4 to 5 years, we have established a fairly robust research and training infrastructure and relationship with partners in India and Pakistan. Our primary partners in India are the Public Health Foundation of India based in New Delhi, the Madras Diabetes Research Foundation based in Chennai, and the Aga Khan University based in Karachi, and the All India Institute of Medical Sciences based in New Delhi. And over the part of 4 years, we have established a Center of Excellence funded by the US National Institutes of Health, and also a Global Diabetes Research Center in partnership with the Madras Diabetes Research Foundation, funded largely by Emory University. And over the period of time, thanks to grant funding, approximately $8 to $9 million have been raised for the partnerships. And we have about, it depends, hard to count, about 60 to 65 people working between Emory and these sites. And I'm glad to say Mark Hutchison, who's our executive director in the audience, he's been a tremendous benefit in terms of understanding the administrative needs for both sides and making all this happen. We also have a very rich two-way training program, and our research is largely based on the public health and epidemiology and clinical trials aspects of diabetes, cardiovascular disease. We have a program funded by NIH where we have postdoctoral fellows from India coming to the US. And we also have a parallel program also funded by NIH where we have US scholars going to India. So it's a very vibrant cross-disciplinary and across people exchange sort of infrastructure that's going on. So based on these, on the one hand, we've also taken a fair amount of new directions in terms of both research, training, and research opportunities. So I'd like to share with you first some broad impressions, and then also share with you what I think have been the major opportunities for such a relationship. And finally, I want to conclude with some of the challenges. In terms of broad impressions, I'd like to share 3 broad impressions with you. First, what we have discovered is for a good, meaningful collaboration to happen, it's very important to identify mutually beneficial areas of interest. If the area of interest is one-sided, it generally does not work. And also related to that, it's very important, like Bill Fagey once told me, for a good collaboration to identify the final mile. You decide what the final mile is, and you try to build your collaboration around that. So, for example, in terms of mutually beneficial partnerships, for scientists in the US, we might be interested in answering certain unique questions, which people in India are too. Like, for example, why are Indians at high risk of developing type 2 diabetes at young ages? Questions of those nature, which are of universal interest, not just to the 2 countries. So that's very important, identifying mutually beneficial areas of interest. Second, this is a tough one, the need to balance both short-term and long-term goals. You need the long-term goals because these collaborations, particularly intercontinental collaborations, are going to take time to mature. But you also need short-term goals to make the enterprise happen and also to make it attractive to funders. For example, in the short term, it is very unrealistic to expect that we can very quickly turn major new investigators in India, but we can do that in the long term because there is a shift in the way in which research is approached on the 2 sides. And also in the short term, it's very difficult to convince major funders to fund our research. Whereas as we show successes, it's possible to do that in the longer term. The third broad impression is really to focus on what is feasible and what is sustainable. A lot of people who come into global health have either idealistic vision of it or have extremely commercial ideas about it. But I personally feel that it is important to identify something which is small, tangible, start somewhere, and then let it grow. And also, relying too much on institutional partnerships, I think is less impressive than trying to build grassroots and then build up the pressure on the system and then allow institutions to get involved. And that's been my 3 broad impressions. In terms of opportunities, again, just to share with you 3 examples of opportunities. The first really is in the area of collaborative science. When you think of the human population, people have migrated from the time humans have inhabited this world. And a lot of genetic mutations, a lot of adaptations to of the DNA to environment has happened over time. And diseases like diabetes are modern expressions of genes or gene expressions that were protective at one time. So essentially, you had populations which had survived famines, and the way they survived famines was because their body was programmed to conserve energy. So you take the same body habitus and you subject it to an environment which is plenty, and then it begins to exhibit what we today see as diabetes. So understanding the genes and the gene mechanisms and gene environment mechanisms requires major global collaborations. And yet, unfortunately, although 95% of the global burden of disease is in low and middle income countries, 95% of global research happens to be in the developed countries, which is about 5 to 10% of the world population. So if you have to come up with breakthroughs, we require global collaborations. And clearly, in the area of diabetes, we are setting up massive population studies. We have about a cohort of 12,000 people assembled between Delhi, Karachi, and Chennai, and in which we are engaging ourselves in terms of studying the genes that lead to diabetes, some of the unique characteristics of diabetes in people of South Asian origin, et cetera. So that, again, the scientific opportunities are very rich. And also, creating that infrastructure allows us to then take advantage of the population attributes and to go after scientific research, which would be of universal value. It's no longer just parochial. So that's number one in terms of scientific opportunities. Second, increasingly as the world expands, and going back to the idea of the bottom billion of the pyramid, the majority of the world market lives in the low and middle income countries. So if you have to deliver health care or health interventions, even in rich countries, you better come up with low-cost health interventions. And this is where connections with countries like India gives us tremendous opportunities. I mean, examples. Vaccines have been produced for pennies. A cervical cancer screening test, which was extremely expensive, the cost of that has been reduced by 100 times. And similarly, in the area of diabetes, the cost of testing of glucose, the cost of developing decision software to manage the process of diabetes delivery, et cetera, we are able to think in terms of low-cost interventions because those are necessities in those countries. And they take time to permeate into richer countries because of barriers. So experimenting in those countries, developing in those countries, testing them in those countries, and then expanding them to richer countries is a very feasible model to do. And that's something we are doing in the field of diabetes and cardiovascular disease. And it opens up tremendous cross connections between, say, Georgia Tech and the Indian Institutes of Technology, between genetic labs in the US and labs in India, et cetera. So that's number two. And the third, this is, again, an important concept, but it takes longer to realize. I think with these global collaborations, the speed of discovery will hasten because you get about a 24-hour window of working together, because when it's day there, it's night here, et cetera. And plus, there are some efficiencies of scale there, some efficiencies of development and design here. So when you put that together, the speed of discovery can happen faster. And indeed, there are models of reverse engineering happening in India. Rather than going through the linear process of discovery, they look at the end product and try to build backwards. So there are some new skills which the environment forces them to think about. And so those kind of things also come into the things. And also the wider pool of people. Essentially, here in the US, on the one hand, we have very well-developed upper-end skills, but we have a shortage of people at several levels. In India, they have a large number of people at different levels. So when you put the enterprises together, it does widen the pool of expertise and the pool of people that's needed. So those are the opportunities. So let me finish my talk, not on a negative note, but on highlighting in a realistic fashion the challenges of bringing all this together. I do think that in the 4 years we have been in this business, we've had a fair amount of success. We've had a lot of frustrations. We have come up with some solutions. Some things have worked, some things have not. But it's a trial and error process, and we learn by experience. But a critical aspect of all this is building relationships. Relationships, and essentially at people level, where you can have open discussions. And sometimes, blunt and open discussions where needed. And the 4 major challenges that I'd like to conclude my talk with, number one, there are major differences in training and human capacity at the two sites. I mean, that is a reality. The US, thanks to 200 years of industrialization and 50, 70 years of major scientific development, has a very strong infrastructure in science, a very strong training program for science and discovery. The type of people that are trained in that system are extremely different. Whereas India, as you heard from the ambassador last night, has had a history of rote learning for whatever reason. And so on the one hand, they're very good at knowledge. Their knowledge base is very strong, but when it comes to applying that knowledge, or in terms of critical thinking, or in terms of challenging paradigms, there are gaps. I mean, to give you a crude example, if I were to pick 20 PhD students at random in the US, I think 16 of those 20 would be safe bets. I mean, they would perform very well. If I were to pick 20 PhD students from India, we would be lucky if we found one or two that would, that's the reality. And I'm not saying this in any disparaging way. I'm saying this based on honest observation. So the question that is often posed to me, but you grew up in India. I probably did, but I was lucky to go to a school that was fairly concentrated more on liberal arts than on scientific education, technical education. And secondly, there's some inborn error in me that allowed me to ignore what the teachers told me. And I often opted to be a bad student in a bad system when I needed to be. So I suppose, but creating that sort of ability to challenge systems is extremely important. The second major challenge is the differences in processes and procedures. I mean, India inherited the British bureaucratic system, which ironically was a system put in place to control the country. I mean, it starts from Macaulay's invention and the Indian civil service, et cetera. But that system has produced people who are very process-oriented and not so much outcome-oriented or results-oriented. So they are very interested in making sure everything works in order, but they're not very worried about what the results of that. And changing that is often difficult. I mean, two examples, again, when we have our bureaucracies, we have an NIH, which is increasingly bureaucratic when it comes to human subjects, when it comes to the idea of management of grants, et cetera. And then we have a similar system in India on the other side, and there are often tussles between the two sides. And then it runs into the conversation as to which is more important. Like, for example, we get a grant from the US. Spending that money in India, we have to go through the Indian Council for Medical Research, and it takes 12 months to get a signature to approve the grant to be spent in India. And changing these is hard, but luckily, the newer ministries in India, like the Department of Biotechnology, the Department of Science and Technology, are much more receptive and much more open. So I think that's where, so rather than changing the existing systems in India, I think creating mutations and new systems that adapt to, like for example, the success of the information technology is that it started on a greenfield site. So they were able to be more open. They were not burdened by the history of the baggage of bureaucracy. The third major challenge has really been about considerable differences in the research and business cultures and the awareness that there can be win-win situations. I mean, very often it's seen as, it's never expressed, but the question is, if we collaborate with you, is there a chance that we'll get taken over? That's the Indian paranoia. The US paranoia, why should we invest in India? We have our own problems. I mean, this often comes up at study sections in the US. So how do you educate people in India and raise their consciousness to the potential of a longer-term win-win? And how do you raise the consciousness of, say, people in the US, scientific, essentially, that there are major scientific opportunities? I think that conversation is a long-term one, but opening that conversation is the beginning of a process that leads to a solution. And in terms of research, like in the US, there are faculty who are fully engaged in research. There are students who are fully engaged in research. In India, research is seen to be as an add-on. People are busy with service delivery. People are busy with other things. So creating the idea that this person is your postdoc or your PhD student or your research coordinator, protect their time for the research, because as the research develops, they're going to need more thinking time, they're going to read creativity, et cetera. That's difficult to often convince them, because when they see people that are employed in research enterprise, they're often used for other areas. And trying to constantly monitor that process and to shift that, takes time. But I think over time, these things are soluble. And my final, the challenge is really one of funding and capital availability, particularly for health research. I mean, and particularly in the kind of areas that I work, like cardiovascular disease and diabetes, which are still seen, even in those countries, as diseases of rich countries. Whereas when you talk of infectious disease, those are easily identified as major problems in poor countries like India or emerging countries like India. And B, countries like the US see infectious disease as a cross-border threat. I mean, it's easy to conceptualize H1N1 crossing borders or plague crossing borders, but it's not easy to conceptualize, say, diabetes crossing borders, but yet I believe it does. I mean, sitting in Atlanta, I often say, we are a hub for spreading several things. We have the CDC in Atlanta, which is a very powerful global public health agency. Although it's a US agency, it performs a global function. We have CNN, which instantly communicates information. And as part of that communication are things like spreading fast foods, the advertisements that influence modern, young people's minds, et cetera. Third, we have the Hartsfield International Airport, which is the busiest airport in the world, and again, a major hub. And then we have AT&T, et cetera. So there is a lot of, I think we have to start conceptualizing today's world no longer as communicable diseases, but also as communicated diseases, where diseases like diabetes, I think, spread faster than we think. And there are studies suggesting that the social networks that spread these diseases are very, very powerful. So let me stop there and just conclude saying that it's been a tremendous experience. I've enjoyed it personally. I'm lucky to have some wonderful people working with me. We have PhD students like Matt McGee, who's in the audience, Mary Beth Weber, and Lisa Steinmace, who are working on projects in India. And similarly, there are lots of people in India working on projects with us. So there's a rich interchange of ideas. And over time, we are discovering, Mark can testify to this, that after a while, you begin to see that the system is seamless. I mean, Mark has open conversations with them, and they have open conversations with us, and we begin to resolve problems. So I think the real issue is having a long-term vision, but also in the short term, identifying short-term opportunities, and cultivating a culture that makes it work. Thank you very much.
May God bless Venkat. He has told the truth, the whole truth, and nothing but the truth. Basically, emerging India is merging India. These are the days in which, with the computer and email language, we always put E in front of everything. So this is E-merging, but it's really merging. Merging in the sense that we have merged with the Muslims who came about 1,000 years back to India. We have merged with the English people. We have merged with the Portuguese. We have merged with the Dutch. So we are merging, and each time we merge, we embrace, like the ambassador said yesterday, so that we are not the same that we were before that. But this merging has been done in a very positive way, and that's what I wanted to share with you. Number one, that after 40 years of graduation from BJ Medical College, Ahmedabad, India, I always longed to go back to the SIM system and see if there is any difference and whether it needs any changes. After a tremendous bureaucratic obstacle, because I was going my money, my time, and no demand. Even then, it was so difficult for me to get into the system to let them see. So my dean asked, of course, that where are you going? So the real name for India is Bharat. So I said, Bharat. And what state? I said, Gujarat. And which city you will be living? I said, Surat. All of them have rat, rat, rat. And therefore, I could see that the best thing for me is not to enter the rat's race at all. For that, I armored myself that I'm going to be a little different and see, and at the same time help them. This is the map of Gujarat. This is Ahmedabad. This is Gandhinagar, the capital of Gujarat. Barodara, so one medical college, second medical college, third medical college from Surat, and then I crossed over to go to Saurashtra, previous Saurashtra, Bhavnagar, Rajkot, and Jamnagar. So I interdigitated a lot with the pathology department, with the administration, and also with the OB/GYN department, in which my main area of interest lies. Many times you have heard the term Mother India, so I just wanted to see that even this map shows we look upon mother because this is the face of the mother. These are the two outstretched extremities of Mother India, and this is the footwork. So that's how we call it Mother India. She's shaped like a mother. But the beauty of India, which was greatly revealed by the ambassador yesterday, lies in its multiplicity. It is amazing how we are mixing with each other without any question. See, when I came here for the first time, I heard the word interfaith. That word was totally unknown to me because I was practicing interfaith all through my life. We had no such questions whether the person is man, woman, Christian, Jew. There was a total automatic, all-encompassing admixture of the population. But this is a good one to show you the diversity, in the sense that the murder of one prime minister by two Sikh bodyguards did not stop us from electing another Sikh as the prime minister. We embrace very, very extremely rich people. We embrace the people who are in Bollywood. We embrace the animals, innocent animals like cow, and also the ferocious animals. We also embrace the plant and vegetables, and that's how we create a map. And still all of them lying on the lotus, which is a classical Hindu symbol. This is perhaps the best representation of what India is and which way it is going to keep on merging. My idea was to study not only the medicine, but the total community after 40 years by living with them. So naturally, the healthcare included the physical aspects, the mental aspect, and spiritual. This is what the Britishers called Dr. Diet, Dr. Quiet, and Dr. Merriman. Diet is being greatly altered. Quiet is almost going away. But still, Dr. Merriman, the spirituality is still very strong in India. Business and technology, we already have heard yesterday. There are 3 arrows on that one. Even the food production is very good. People are not hungry anymore. And those people who cannot afford food, it's amazing how many charities are running there. No tax deduction asked. They just work there. They prepare food, somebody gives food, there are no names on it, and those who are hungry, they are fed. This, to me, was very, very cheering situation that I saw. But the physical health is really suffering, no matter what we say. There are so many problems, and I cannot enumerate all of them, but number one is poor hygiene. Dr. Sheth said yesterday that once you get over that, you'll start enjoying India, which is truth, but partial truth. Because a part of the sanitation, and especially when I saw a lack of sanitation even in hospitals, then I really gave up on that one. That is one place we want to be immaculately clean in a scientific way. It was not so. Air pollution, well, the basic principles which Hindus prescribed, the water, the fire, the wind, the sky, each one is showing the signs of pollution. Homeless people are still there. At each medical school, I used to go for a walk and see so many happy homeless people. The conditions are definitely crowded, particularly in big cities. And the stray dogs and animals is another thing which needs to be noticed. Yesterday, when Dr. Apte talked about the diapers, I told him that diapers might be disposable, but how you dispose the diapers is also a very important question. Because right on the street now, they throw away the diapers, the plastic bags, and some of the stray cows, they choked on it. And these are the kind of things which needs to be addressed. Mental health, I cannot talk much about it at this point, but mental diseases are still a stigma. People hide it. They do not come out of that one. And there are so many mentally suffering patients, and some of them can easily be helped. They are not getting any help there. Secondly, interestingly, like the typical tradition of China and India, where the old people were always respected, listened to, and obeyed, that is changing. I used to walk in the parks, and there I saw amazingly that there will be old couples talking about the same thing. We do not see our children anymore. They do not talk to us anymore. The houses in which they have put us, it might have AC. We do not care. We want a veranda with a swing on it. There's nothing like that, so on and so on and so forth. There is no question about that. People are generally very happy. And on my journey, each time I saw some medical students or some students from Europe, they were joining from my first halt, and each one of them said that they are going to India because they find the people to be very happy, and they want to see that happiness. Many of them said, I said, aren't you worried about getting some kind of infection? Oh, yes, I had infective hepatitis last year when I went there. So I said, did that stop you from going this time? He says, no, I'm still going to go. So this is the way the mental framework in those people is working. Ritualistic life continues, but at the same time, the spirituality is somewhat fading out. We do not understand Vedas and Upanishad, to which the Westerners are attracted enormously, because it is a spiritual science. It is beyond religion. It does not have any dictation. There are no commandments. Suggestions, you follow, and you inquire yourself and find out your truths of life. That, to me, is amazing. Unfortunately, it is coming back here, thanks to Emerson. Emerson was called the American mind. He was that brilliant. And when he read about Vedas, he was attracted to that. Coming to medical education, there are certain things very new. A number of new medical schools emerging without a vigilant quality control. That was dangerous. Inadequately, doctors can be very bad. Instead of that, the kind of the British system that have 2 or 3 years of practical training and let them be taking care of the 90% of the common diseases by giving them a license called LMP, Licentiate Medical Practice, so that they help out the people, and for all these sophisticated diseases, it can be sent to the doctors or the specialists. That, I do not know about that. There are less visible teachers, very, very alarming. Because when I was there as a medical student, and I was a teacher myself, we were not allowed to practice in a private setting. Instead of that, per month, we are giving X amount of rupees for not practicing. That is called non-practicing allowance, NPA. Now, the government says we cannot afford to give them that non-practicing allowance, so let them practice, but we'll save the money, a very meager amount of money on that NPA, with the result that after 3 o'clock, most of the offices of the teachers are empty. They're out there practicing instead of teaching. Dangerous. Medical students are very bright. When I ask them, they are very inquisitive, but unfortunately, they are not focused. As opposed to that, I see the medical students here, they pay a lot of price for their medical education. They come after full 4 years of training, and therefore, they are more focused on life. They know exactly what they want to do and why they want to do it. This is the reason why now you can see that most of the medical students at Emory, they want to go to public health. Right on the day they apply for an MD program, what do you see yourself to be doing? Public health. Not only that, in this public, it's a very unselfish motive. That's why I'm very much impressed by them. It's unselfish because after doing that, they say, we want to go to Mexico, we want to go to India, we want to Bangladesh, and help the poor, suffering people. And then I have to caution them because I'm partly at Emory Hospital and partly at Grady Hospital. I said there are deep pockets of poverty here at Grady. Be volunteer here also, because this country also will need this kind of a volunteer help. The libraries are very poorly equipped. Most of them asked me that, will you please send us these books, because they were reading and following the books that were about 7 to 8 years old. Sad. On the other hand, fancy gadgets are flowing into the hospitals, especially teaching hospitals, because that is something which you can show, you can demonstrate, you can be proud of, you can boast of. This is the ribbon cutting ceremony that yesterday we were talking about. That this kind of an instrument you put there, and you can have a minister who comes there with an applause, he cuts the ribbon, and then the instrument or the gadget is uncovered and never used then. I saw so many such expensive gadgets that were never used and lying just there gathering dust. Administration eclipsed by bureaucracy, and I think if I say anything more than most of you will throw up, because yesterday you heard about bureaucracy, 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 bureaucracy. Most of the deans are busy traveling between Bhavnagar, Rajkot, and Gandhinagar, where the capital is, for some kind of a meeting. I like the American way of doing it. Make it practical. Use minimal time in wasting. Straight to the business and get it done. It's not done that way. And a strong family support. That is the part I so much was happy to hear that. Because I used to, we have got that ladies' lunchroom and men's lunchroom. And even the ladies' lunchroom, they said, that's okay. We have got tiffin. Why don't you come and join us so that we can talk? And I talk to them. And they say, we have no problem because I have a child, but my mother-in-law and my father-in-law are keeping the child. They say, no, you study and you become smart. We can easily keep the baby. That kind of a supportive thing was not very existing when I was growing up. But then India is, the opposite is equally true. When working on the WHO panel to see the utility versus futility of quinacrine, which is used in some of the poor countries for sterilization, it has so many pluses and minuses. In that process, I came across a book called The Unheard Screams. And this is all about those women which we do not talk about. We want to talk about the poor people. That's my concern. The rich people, the educated people, they will find their way for their own welfare. What about the poor people? These are the women who are paying an enormous price for all kind of substandard experimentation, and that's what I found out from that one. This is so true for there, but like I said, it's true for here also, particularly when I work at Grady, that comes to my mind. Unequal availability in big cities, it has been very well known. Another thing which greatly struck me, traffic is enormously increasing. Yesterday, the ambassador was talking about making the new vehicles and so on and so forth. India cannot afford to have any more vehicles on the road. There are more than enough. They add to the air pollution. They do not increase the mobility. And on the other hand, especially on the highways, there are such bad traffic accidents, and it might take hours and hours before you get the medical help. We do not have any specific training in trauma centers and trauma surgeons. So you only pray God that there might not be any accident when you are on the highways. Good point. Blood banks. It is amazing how many people were volunteering to work in the blood banks. I was amazed. They are totally dedicated to that one. They go out in this thing, supply blood, take blood, so that shortage of blood was a very, very less heard problem in the hospitals everywhere. So now, what we need to do, we do need a Flexner-like report. You know, India, this country had the same problem. There are so many substandard medical schools, and Flexner came out, and he cleaned up the mess, and so many medical colleges are shut down. And only those that were viable were allowed to continue. We need such a strong Flexner report so that the medical schools in India get a good quality control. Public health, and Venkat already said that. Venkat, that's exactly what we do need in India. More and more people who come from here, they interdigitate with them and reach out to the most dire needs, the health needs of India. Diabetes, amazingly, most of the even educated women, they have a big breast cancer, they never go for that one. Pap smear, such a routine. It's a welcome wagon when you come to the hospital for women. Pap smear, most of the women did not even know about pap smear. Those are sad ignorances. And now I see that there are many students, not only necessarily of Indian origin, American students, they want to go to India and spend some time there learning about the society, the health needs, and so on and so forth. So I think, now we can hopefully make an official thing so that, they are given a decent residence there, decent, clean food, and an opportunity to see what the rural medicine is like in India. They would love it, but there is no such existing formula right now so that we can suggest that you want to go, okay, these are the things that you have to choose from. These are the centers which are ready for you. We don't have that. I think that will be our dire need of today. And of course, the public health, but I think even this country is now expecting a lot of shortage of doctors. That's the reason why Emory is modifying its curriculum to make it more clinically oriented. But how a country like India, which is 1 billion plus people, how can you find doctors for all of them? So the best thing is train every one of them to know about their body. That is the function of the public health, yes. He asked me to stop, I know, but usually to stop a priest from speaking is called blasphemy. All right? So I would stop with this from Rabindranath Tagore. He was a Nobel laureate and a poet, and he wrote down that where the mind is without fear and the head is held high, where knowledge is free, where the world has not been broken up into fragments by narrow domestic walls, where words came out from the depth of truth, where tireless striving stretches its arms towards perfection, where the clear stream of reason has not lost its way into the dreary desert sand of dead habit, where the mind is led forward by thee into ever-widening thought and action, into that heaven of freedom, my Father, let my country awake. I would say, let the whole humanhood awake, not only India. Thank you.
Partly because of my godless act, we have a little time left for discussion. And I think that Dr. Majmudar, when I mentioned that there was a time constraint, he told me that he would, if he would not translate his talk into Sanskrit for us. Any comments or questions?
I want to talk a little bit and ask a question about the private sector of healthcare in India. I was there last month and had a chance to visit many of the private hospitals as well as the government hospitals, the likes of Escorts, Apollo, and then in Bangalore as well. And as you well know, that they're performing, as we heard, many of the surgeries at very, very low cost. And the whole idea of medical tourism is sort of moving ahead. My question is, do you feel that not unethical may be a very strong word, but some type of an ethical pull in a nation like India, putting its resources to provide health care for those who are overseas, while it struggles to put its own doctors and nurses to care for its own people? Is there an ethical question that comes to your mind in the whole idea of hospitals which are Joint Commission certified in India and very, very capable, equal to hospitals here, putting their resources and best doctors for foreign patients?
You know, the question that you raised is not only for India, but the same thing I heard about Thailand also. That what is happening, that people who can afford, they go to Thailand, even from this country, with the result that most of the good medical doctors go to those hospitals which are well paying, in many ways clean to operate, and there is a dearth of supply for the average Thailand citizens to be treated. So again, it's a shift of power caused by money. So in India right now, there are many Americans who are interested in going there for treatment because we have got extremely qualified specialists there. They have been trained overseas, so they can give the same quality of care. At the same time, money is less, and more than money, the infrastructure is very good there for them because the nurses give a very delicate care, which sometimes you do not even see here. So this is not an ethical question, not an unethical question. It is a practical question to which I do not know what correct answer is going to be. To me, I'm a medical educator. To me, the idea that we are teaching the medical students from their cradle that you are choosing this job, choosing this profession to serve humanity, not to fill your pockets. If you keep on repeating that, then perhaps we might create a volunteer of people who are dedicated to the humanity at large. It's amazing how Louis Pasteur said that in the coming years, he was a great researcher himself, but he says in the coming years, those people who help the suffering humanity will be the most respected people.
If I can add to that, I think something which Ambassador Schaefer said yesterday during her presentation, to the closing of your presentation, is extremely important. The development in India is going to be very chaotic. You're going to see all kinds of paradoxes. That's the nature of the beast. And so you will have these higher-end hospitals that in-source care or outsource care, and you will have the other side struggling. So both these are going to exist. So rather than taking a moralistic position on that, I think a more constructive position would be, A, how do you expand medical education in India so that the country produces more doctors to meet its needs of higher quality? And B, how do you regulate the current healthcare system, be they the large Apollo hospitals or the smaller hospitals, so that a quality of care framework develops over time? I think those are much more important. And I think, to some extent, allowing the market forces to operate. I think that should be important. My view on this.
There is one relevant example in this country that Macon started with a medical school with the requirement that they all will write down that they will go to the rural areas of Georgia to practice medicine so that the poor distribution can be that way controlled. One time, a medical student graduating from there applied for a specialty here, and the dean said that I will not write you a good recommendation. It went into court, and the dean lost. So ultimately, it is very difficult to direct or command the medical person to choose his career according to the need of the country.
You know, another way to look at it is, I would say you ain't seen nothing yet. It's a global marketplace. For the last 10 years, the United States has been importing about 15% of our physician workforce from South Asia, from India and Pakistan. They stay, and like the other 1.5% of the American population from those countries, their children excel, and about more than 10% of our medical school class are children of that diaspora. So our country is going to grow up increasingly comfortable with and expecting to be receiving their medical care from people from South Asia. So why not go over to South Asia and get it? You know, and I think I don't think we're going to see less of this, particularly as we continue to spend $9,000 per year per capita for health care in the United States in an increasingly unaffordable way with increasingly higher co-payments and increasingly poor insurance. So I would expect that this is a huge growth market. So if you can buy the stock, buy it. Whether it's good or bad. I mean, it's inevitable. I don't see how you can, unless you regulate against it, then that has all kinds of other issues. Any more comments or questions? Dr. Sheth.
How many weddings have you performed so far?
This is about healthcare that we are discussing.
Oh, I'm sorry. Are you in the Guinness Book of World Records of weddings in America?
I will give you a little more relevant answer. I've officiated about 225 weddings, and my main interest, I'm a specialist, so I've got to be a specialist. So interfaith marriages is my specialty. It's amazing how many interfaith marriages are taking place, and I'm just wondering what is going to be the structure of the society in the coming years, because this interfaith marriages is going to create children of no particular color, of no particular creed, no particular culture, no particular religion. And what's going to happen? It will be very interesting to see that.
Jim, can I make one comment? I was on the board of Manipal group, which is one of the largest teaching hospitals. There must be in 8-9 countries. In the country of Malaysia, because of the Indian settled in Malaysia, multi-generational, going to India to get their medical degree, the Prime Minister Mahathir found that 25% of all medical doctors in Malaysia were of Indian origin, which is a minority there also, and by 2020 will become 90%. And therefore, from a social, civic agenda, he found that as unacceptable. So there is a public-private partnership whereby Manipal was invited to come to Malaysia in a city of Malacca, which is the old capital. I've gone and visited that, so that the Chinese Malay also can have access to Indian medical education. There's a punchline. The intake now is more than 400 students. The Indians who came were strictly on what's called capitation in terms of fees and all the typical non-resident fees that we charge. And first 2 years, they go to Manipal to get the basic sciences training. Last 3 years, clinical is there in Malacca. So the total pool has expanded now. The message is that, surprisingly, many of the Indian medical schools are going to expand globally into other emerging markets. I think that aspect of collaboration we need to understand better. Manipal, for example, is in Caribbean islands. They may buy one of the medical colleges or medical hospitals in this country, in the heart of this country, because largest number of non-resident students that they get now is from North America. They're already in Bhutan, they're in Sri Lanka, they're into 9 different countries. I think we haven't understood that architecture and its impact, for example, on India's actually supplier to rest of the world as a medical facilities. Very interesting, both education, that's true of Apollo group, for example, that's true, of course, to some extent, the Manipal group. Those 2 groups seem to be going international more so than just receiving the things on our side.
I was speaking with the ambassador last night at dinner and talking about the old India relationships with countries and also the old view of international health in the United States. And our traditional view when I was, 20 years ago was that the main concern we had when we were educating professionals from developing countries is that we were concerned that they go back to the country and work in the country to fulfill the country's needs. That's not an unimportant concern, but it's a little bit different now. The other thing is that we were talking about Indian diasporas to different countries, of which I know nothing, except that the Indian diaspora to the United States, the average insular American who's never been out of the United States sees Indians as doctors and engineers and scientists, the highest income group in the country. It doesn't see poverty when it meets it on the street. So its view of India, if you listen to CNN, you may have a different view, although then you're watching Sanjay Gupta and Fareed Zakaria, So the thing is, you don't still have that view of India as a poor country, nor do you view Indians as poor or ill-educated in any way, shape, or form. And I think that, 20 years down the road, the view of Americans and the view of India is going to be shaped by what they've experienced on a daily basis rather than even the realities. And the idea of the global marketplace for physicians is an interesting one, and I think it's an inevitable one. Independent of whether it's good or bad, it's certainly not going to be shaped by our view of the past any more than anything else. So I'd like to thank our panelists and thank the audience.